oversight, so I'm just going to go ahead and start it so that we can have some time to have really fun conversations. There will be lots to talk about, I'm sure. So I'm particularly honored and excited to introduce Dr. Chambers. Dr. Brittany Chambers is an assistant professor in the Department of Epidemiology and Biostatistics and California Preterm Birth Initiative at UCSF. Dr. Chambers is also a K-12 Building Interdisciplinary Research Careers and Women's Health Scholar with the Bixby Center for Global Reproductive Health. Her work focuses on partnering with Black communities to understand how interpersonal and structural racism impacts Black women's reproductive outcomes, to inform policy and community and individual level interventions, to optimize the reproductive health and well-being of Black women and families. And I'd like to add that her work provides a critical lens with which the field of psychology and psychiatry can promote the development of more equitable social and political institutions. Indeed, to remind you all, much of psychological science and knowledge is significantly relevant to social justice, defined as the goal to decrease human suffering. So please join me in giving Dr. Chambers a warm welcome. So I'm really excited to be here with you all today. And today I'll be talking about institutional and structural racism and implications for child and adolescent health. So by the end of this talk today, you all will be able to describe racial disparities in maternal and infant health outcomes, define racism and how it's measured in public health research, understand the relationship between racism and infant and adolescent outcomes, and describe policy recommendations to improve educational opportunities and economic growth in Black communities. So as was mentioned, my work really sits within the maternal and child health space, really focused on understanding and advancing disparities in reproductive health. So here are data from California from 2013 to 2015, and it shows the percentage of Black, which is the gray, and white women, which is the orange, in health outcomes across the reproductive care continuum. And so it covers the percent of inadequate prenatal care all the way to infant mortality. And here what's clear is that there are disparities across the reproductive care experience and outcomes. So here is a graph of preterm birth rates across California counties. And it's really important graph for us to really understand why it's important for us to start looking beyond individual level outcomes and start looking at things such as structural racism to understand what's going on. So here are percentages of preterm births across the state of California. The counties that are in darker orange show that the percentage of preterm birth rates are higher than the state average, whereas the ones that are in lighter orange shows that the preterm birth rates are below the state average. And so one would probably start hypothesizing that there's something that's going on around these counties or structurally that's contributing to these disparities. And here is an inside zoom of preterm birth rates within Fresno County, and all of the census tracts that have the highest preterm birth rates are really clustered in one particular community that happens to be a predominantly community of color. So myself, as well as other research scholars, have started to look within pregnancy context to look at exposures such as racism, try to understand how this is influencing reproductive health outcomes. So before we get started, I think it's really important for us to have a solid definition that we will all use collectively together to understand racism and its relation to these health outcomes. Here is a definition by Dr. Tian Parker Dominguez, which I love, and she defines racism as a system of domination and oppression based on physical characteristics such as skin color and or racial group affiliation, rooted historically in ideologic beliefs about the innate superiority and inferiority of certain groups, whereby one racial group, which within the U.S. context are whites, derives benefits and privileges from the systematic and pervasive subjugation of other racial groups, which are non-whites. But within the U.S. context, there's research to show that the exposure of racism worsens for people who are Black, and that there is a gradient dependent on people's racial ethnic group in proximity to whiteness. So when we look at racism, there are levels of racism, and Kamora Jones defines this very well in her Gardner's Tale. But what has been clear across research studies is that racism constitutes a perceived threat, a severe threat to a person's health and well-being, and is considered a chronic stressor. And when you go into the levels, it's important to note that in order for racism to exist in a society, that all levels must coexist collectively. And so structural racism is the implementation of processes and laws to advance one group over another within society. And interpersonal racism is the direct contact between one person, so discriminated against a person or treating a person unfairly based upon their racial or ethnic group. And then internalized or self-racism is taking on negative stereotypes associated with your racial group affiliation and taking on those or embodying those characteristics. So how does racism show up? So here is some work done by the Green Line Institute, and it is to your left. You'll see the graph of redlining that occurred in 1937. So the maps with high risk are marked in red, and then directly beside that map is a more current view of toxic hazard levels. And one could really conclude in that in areas where you see really high exposures to toxic air, that it overlaps with those communities that were marked at risk during redlining. And so a lot of researchers have been using this as a way to develop and define structural racism and how it's related to adverse health outcomes. And for some people, it's really hard to understand how structural racism then boils down to how people experience racism or their interpersonal accounts. And so due to social media, we get to see this all the time. And this is really how structural racism has showed up this past year on social media. So here is a nurse who's taking a picture with a Black baby, and this showed up on her Snapchat. And she said, "This is how I currently feel about mini Satans." She was then fired from posting this. And then here is another picture of someone asking someone to prom. So if I was Black, I'd be picking cotton, but I'm white, so I'm picking you. Also, we saw on social media why America's Black mothers and babies are in a life or death crisis. So here people really calling on racism as the cause. And then also it shows up in the U.S. support of formula over breastfeeding, saying that this is indeed a racial issue. So here to really just point out that people's perceived notions of Black people and Blackness was just really rooted in structural racism in developing those cultural and societal norms of Black people, and what it means to be Black is really deeply embedded in racism, explicitly and implicitly impacting the ways in which providers view Black women, their concerns, behaviors, and care treatment. And so moving on to how do we measure structural racism? So the most common way in which we measure structural racism in the health science literature is through residential segregation indices. So there is really strong evidence to show that things such as redlining really is associated with negative health outcomes. So a group of scholars developed residential segregation indices. There are 5 of them. And the first is the dissimilarity index. And this measures the proportion of the minority group that would have to move to another neighborhood to achieve complete integration. And there's the isolation index, which is the probability for interaction between members of the same versus a different racial group in a given neighborhood. There's centralization, which is the degree to which a minority group is primarily located in a city core. Concentration, which is the spatial density of a minority group in an area. And then clustering, which is the grouping of racially similar neighborhoods in a space. And so these indices have been used for ages, like they're developed in 1988, and people have been using them for years. And then there's been a group of scholars who have really been trying to look at new ways that we can measure structural racism, and really acknowledging that, yes, residential segregation is a really good way to measure, but that structural racism does show up in different ways within our community. So novel measures that are currently in the literature looks at racial inequities in political participation, employment and job status, educational attainment, and judicial treatment. And so these were put forth by a group of scholars, and they look at Black to white ratios across these domains. And then most recent has been the index of concentration at the extremes, which looks at social polarization of privilege to deprived groups across an aerial unit. And so to date, these are the ways in which structural racism is measured, and I have been able to look at all these in my work, and so I'll share a little bit of that with you all today. So here is an article that I published in 2017 and was a part of my dissertation work. So I was really interested in seeing whether traditional versus novel indicators of structural racism helped explain the white to Black disparity gap that we see in adverse birth outcomes. And I did an incremental approach in this. So first, I built my model with first looking at the individual level outcomes that we know are associated with adverse birth outcomes, such as hypertension, receiving prenatal care, previous preterm births, educational attainment, and then I added poverty into the model, and then I added, so community level poverty, and then I added the indicators of structural racism. And so here is a summary of results. So I found that after accounting for individual level factors, that poverty did explain more variation in adverse birth outcomes, and that county level poverty increased infants' birth weight. No, it decreased. It decreased infants' birth rate by about 0.5 of a pound, and it decreased gestational age by about 14 days. And then adding in the indicators of traditional and novel indicators of structural racism, we found that, as previous research had found, that traditional indicators of structural racism did explain differences in both Black and white women, and that it was the only indicator to explain some of the inequity gaps that we saw, and that was with using the isolation index. So we found that Black women who lived in counties with higher isolation birthed infants about 3 days earlier than white women residing in similar counties. And we didn't find that the novel indicators of structural racism did describe any additional variance, but we did find, what happened? But we did find that that these indicators did describe adverse birth outcomes for both Black and white women. So as a postdoc here at UCSF, I did look at the index of concentrations at the extremes. And here in this particular study, given my previous research as well as research that's been published by other scholars, I feel like there is known knowledge that structural racism is associated with adverse birth outcomes, and that it could help explain additional variance that we see between Black and white women. So in this paper, I just zoned in on Black women to try to understand how structural racism shows up for this particular group. And I did that because Black women were a heterogeneous group, we're different, and so it was really important to do this in-scope analysis to try to inform policy. And to describe a little bit more about the concentration of extremes index. So it looks at social polarization. So one of the indices looks at just income. So it looks at those who made 100,000 or more in comparison to those who made 25,000 and below. Within a certain county. The race just looked at black to white. And then this was the first time ever in literature where we saw an interaction, one variable, but looked at the interaction between race and income in one variable. So it looked at race and income within a particular area unit by looking at whites who made 100,000 or more in comparison to blacks who made 25 and below. And so what we found with this is that black women who lived in the least privileged race, income, and race income quintiles had a 15 to 29% increased chance of having a preterm birth in comparison to black women who lived in the most privileged quintiles. And then for infant death, we only found that the race plus income measure of structural racism was associated with infant death after controlling for all the individual level factors, and that black women who lived in the least privileged race plus income quintiles had a 54 to 68% increased chance of experiencing an infant death compared to black women who lived in the privileged quintiles. So now moving on to ways in which I have measured institutional racism, and it stems on the same premise of how we understand structural racism, but I'm considering institutions things such as, SFGH, such as schools. I use the AdHealth data set, which is a really large data set that oversamples for Black and Latina youth, and is nationwide. There's several waves of this data. But what's most interesting about this data is that it does collect information around students' perceived inclusion with their peers. It also collects information around how they perceive their teachers' fairness. And it had information around the proportion of Black teachers who are actually teaching at those schools. And so here I was interested in looking at those things to see how they are associated with delinquency behaviors. And I think this may be interesting to some of you also. This study did refute some of the norm or typical norms that people think around Black students and delinquent behaviors. So we did find that as the number of male students increased, that students' delinquent behaviors increased. We found that as the number of Black students increased, that students' delinquent score behaviors decreased. And then when we went to look at their perceptions of inclusion and fairness, we found that as students' levels of perceived teacher fairness and peer inclusion decreased, that their delinquent behavior scores decreased. One thing that I found was the key takeaway from this particular study is that we found that as Blacks in teaching roles across schools increased, that students' delinquent behaviors decreased. So as we're increasing teacher diversity, that we see better outcomes in delinquent scores. So across all these studies and all the work that I have done with looking at structural institutional racism, I would say that these measures didn't explain as much variation as I expected in these outcomes. And I really sat and thought about what is really missing from the story. And moving back to my work around structural racism and adverse birth outcomes, this was really missing Black women's voices. So all these measures were created with researchers together, sit in a room and say, hey, this is how we should be measuring this. And I hypothesized that this was one of the reasons why we weren't seeing the variance expected. And so this was a study that was funded by the Preterm Birth Initiative, and the second phase was funded by an Health Equity Award here at UCSF. So the first phase of the study was to explore how Black women residing in Oakland and Fresno conceptualized structural racism and its potential impact on reproductive health outcomes, including preterm birth. In phase 2, I used the Linda Frank et al. Research Prioritization by Affected Community strategy to collaborate with Black women in Oakland and Fresno to identify policy recommendations for each of the unique domains of structural racism. And for this work, I partnered with Black Infant Health, the Breast Friends Mommies Group, Black Women Birth and Justice, and Roots of Labor Birth Collective. And so I really wanted to highlight my team. So in this work, we've used a reproductive justice framework. And what that really means, one part of that framework and what it means to us is making sure that our study team reflects the population. So here is our study team. We had program coordinators for both Oakland and Fresno groups. Dr. Monica McLemore was my faculty mentor on this project. We did have 3 community researchers in this work, one representing each geography of the California Preterm Birth Initiative, where Brandy Gates represented Oakland, Brianne Taylor, San Francisco, Loretta Scott Leach represented Fresno, and then we had 2 students who worked on the project across both phases. So we collected the data to develop the conceptual framework between January and May of 2018, and we met with women across the reproductive lifespan. So we had 32 women total, 5 women were preconception. We had, math in my head, 13 women who were pregnant, and we had 14 women who were postpartum. The inclusion criteria was women self-identifying as Black. They had to live in Oakland or Fresno. And the way in which we described our reproductive Black track, so preconception were women who never had a live birth. Pregnant, they had to be currently pregnant at the first focus group. And then postpartum, they had to have a child that was less than 12 months at the time that we had our first group. So we had a series of focus groups. The first focus group really focused on having Black women define structural racism and describe how it showed up in their communities. And then we met as a group, myself and the community researchers, and we used a constant comparative method to review the transcripts, develop a code book together, and then we use that code book to then go and code the transcripts for the focus groups. We had 2 coders for each of the transcripts, and we met on a weekly basis while we were doing this. So all coding discrepancies were discussed and decided as a team, and then collectively we identified emerging themes, patterns, and domains of structural racism. So after doing that, we then sent our conceptual framework, definitions, and representative quotes to an expert advisory board. And again, using our framework, it was really important for us to have Black women scholars who are known for doing this work. So we had Cassandra Juber, who is a professor at Fresno State, representing Fresno geography. We had Imani Allen, who's a professor at UC Berkeley, representing the Oakland area, and Joy Perry, who is the founder and president of National Birth Equity Collaborative, who represented the national perspective in this work. So we then sent the conceptual framework, domains to our expert advisory board. They were able to review these. We gave them a template for them to say whether or not they felt like the domain that emerged represented structural racism, if they felt like it was a cause or effect of structural racism, if they had any feedback on how to improve these domains. And then I had one-on-one conversations with each of them to better understand their concerns, and then we addressed those. The final step in this was then going back to women in the community and doing member checking. So from the data that we've collected, as well as a consultation with our expert advisory board, we then created a slideshow presentation for each of the groups across the 2 geographies that contain definitions and data of structural racism and how it showed up from their own focus groups. And we asked them if the definition of structural racism reflected their experiences. If no, how should it be revised? We asked them what were their initial reactions to the domains of structural racism that emerged from their experiences. do they have any recommendations on how to change and or improve the domains of structural racism? And then we had them sign to say that they agreed that what was presented, what we came up with, was a reflection of their experiences and stories. We did allow for women to verbally express these. We also developed a document for people who really weren't comfortable talking all the time to be able to provide feedback to us on paper. So I would say the things I'm most excited about this work is that we shared these findings first at a collaboratory in July 2018, and here's a picture of the room. We had close to 200 people who came to this event, and the most important thing is that women were involved. So when I went to the communities to first talk about this study and ask women to join, they said, well, Brittany, what are you gonna do with this work? You know, what are you gonna do? Why should I be involved? I'm tired of being in research studies. And I told them, you know, to be honest, like I would love to write a publication from this. I also would like to inform policy with this work. And I also want to take you guys along the way to really understand the research process. And so we were able to hold this collaboratory during the lunch hour, which really isn't typical for the Preterm Birth Initiative. They're usually in the evening. We were able to provide a bus for the women from Fresno to come up to the event. And the women from Oakland were able to attend during their lunch hour. So a lot of them said this was the first time that they've ever been a part of the research process like this. And we're really excited to see that other people were excited to hear their stories and were engaged in this process. So here are some of the demographic characteristics of our sample. So the majority of women were aged 25 through 30. About 78% of women made less than $2,000 a month. Women had various relationship statuses. So you see like, it's kind of like an even split across them all, where women reported being single, never married, in a relationship but not living with their partner, in a relationship living with their partner, or being married. And then about half of the women, they wanted more children, just not now, or they wanted children if they're in the preconception group, just not now. And then we had a lot of people who said the other category, which was really deciphering what they really wanted to do around the reproductive goals moving forward. So some of the data from this, so these are the ways in which Black women across reproductive lifespan define structural racism. So women from the preconception group in Oakland define structural racism as the compounded historical effect of institutions and disparities that were used to systematically oppress a group of people while advancing another group of people. The pregnant group from Fresno described structural racism as biases towards a racial group created and perpetuated by governing bodies, such as government officials and police officers, that affect certain racial groups' access to resources and adequate medical care. The pregnant group in Oakland defined structural racism as systematic laws and processes that are used to oppress a group of people and has a trickle-down effect, forming and perpetuating racist ideas and stereotypes. The postpartum group in Fresno described structural racism as unequal distribution of resources to neighborhoods that makes it challenging for a group of people to thrive. The postpartum group in Oakland defined structural racism as a silent opportunity killer that regulates access to resources, better education, and safe neighborhoods for a particular race. From these definitions, we then asked Black women to describe how structural racism showed up in their communities. And this is how they described it. So the top portion are domains of structural racism that were prevalent for preconception, pregnant, and postpartum women. And they defined domains such as negative societal views, which they defined as historical and contemporary narrative and false representations of Black people that create and perpetuate damaging stereotypes. Medical care, which they defined as racial inequities in access to and engagement in adequate reproductive health care. Employment, which they defined as unequal employment opportunities and support, including during pregnancy and the postpartum periods for Black women and families. Law enforcement as racial inequities in the number and type of interactions with police officers. housing as systematic laws and supports used to discriminate against Black individuals and families, and funding adequate housing and safe, resourceful neighborhoods. Hidden resources, lack of knowledge of availability of community resources and programs addressing women's health issues. In education, educational system explicitly and implicitly designed to create and sustain racial inequities and disciplinary acts and access to resources in the school system. And on the bottom, these were domains that only came up for pregnant and postpartum women, and that include policing Black families, and they defined it as lack of laws and processes in place to support Black families and community infrastructure, and they defined it as racial inequities and community assets and deficits. And while we were talking with Black women, they organically start talking about ways in which to combat structural racism, and so the domain "It Takes a Village" emerged. And they defined it as uplifting the Black community through advocacy, solidarity, and the establishment of Black-owned businesses to increase job opportunities and community wealth. Today, I'm going to share stories from the educational domain and the community infrastructure, because I believe that the stories in which Black women shared align most with child and adolescent health. So again, just to remind you of the definition, definition for the educational domain is educational system explicitly designed to create and sustain racial inequities and disciplinary acts and access to resources in the school system. And Black women describe education in the US as a system that does not provide equal access to opportunities for Black children, adolescents, and adults. Yeah, Zachary. So one mother expressed her frustration about the lack of educational opportunities for Black children. She described, like, personally, a lot of our children are having difficulties in school, and there's different factors that contribute to being autistic. It just means that you look at the world different, you know what I mean? So our children needs IEPs or special ED, things like that. The school, don't offer those. They'll let your child, I'm telling you, they'll let your child go through the school and not say nothing to you. A woman from the preconception group spoke of a similar challenge with receiving unequal education opportunities as an adult. And she described, I'm in this lactation program. The program found me a preceptor. She ended up being a white lactation consultant, private practice. And I always thought that I was going to be somebody different. I always thought that she thought that I was going to be somebody different. And when she interviewed me, and so I interviewed with her. She said I could precept under her, and how it was going to work is where we're supposed to. I had to get 300 hours, and she was like, I can probably give you 100, but since she's private practice, she has to tell me when she's seeing people. The program starts in September. I gave her some time. I emailed her early October. Hey, can I get your schedule? She doesn't respond. And so I follow up 2 weeks later, not trying to bother her too much, being a passive Black woman, like, oh, I'm just wondering if you're still there, can I get your availability? So she does email me back, and she gives me, I want to interview again, basically, to see if I really want to work with you, she said. Yes. And I was part of this report that came out, and she bought the report and said, holy shit, it sounds like you're a part of this report. Here's my schedule for the next week. And I was like, oh my gosh, like, I've been working with you for 3 months, waiting for you to give me your schedule, but it wasn't until you bought this report and you found out that, that it sounds like a big deal now that I'll give you access to my calendar. So I was torn, because I'm like, I want to know what private practice is like, but you're hella racist, and I don't want to continue to work with you if you don't want to work with me. Black women, particularly mothers, also expressed inadequacies with the school system disciplinary practices. Women describe that Black children are not given chances to thrive, and teachers often give up on Black children far too soon and often in comparison to children of their race ethnicities. Here's a quote from a pregnant woman, and she describes, even in school, they'll be like, you could have a Black child and you could have another race child, and both of them can act out. But they're going to take their time with the white child and be like, oh, this and that. Oh, let me help this. Let me calm this child down. They'll be like, with the Black child, something's wrong with him, call his parents, send him home. And another woman from the pregnant group in Oakland, she shared similar experiences with her son once migrating to the US. And she expressed, so the school called. Anytime my child do something, they call me, and then I go to school. He got referrals, he got suspended, of which when they tell me the reason, I will understand. But then it got to the point where I asked to come to the school and sit in the classroom with my child so that I can help him, try to see what's happening and help. I've noticed that there are some other students actually who are doing more than what my child was doing. But maybe when I looked in the classroom, the surrounding, the teachers, the principal, everyone else was like white and you're black. So I've noticed that there is some kind of racism because they always talk to those students. Like if they do something, teacher will calm them down and tell them they're wrong and give them time out. But if it's my child, even in my presence, they'll suspend him. So women across the reproductive lifetime expressed receiving inadequate access to resources, unfair disciplinary treatment in the educational system, and exposure to racism being an integral part of this process. Now moving on to the community infrastructure domain, Black women define this domain as racial inequities in community assets and deficits. And Black women expressed how systematic decisions led to disenfranchisement of communities of color, including access to healthy foods and safe and thriving environments for children. So a woman from the Oakland Pregnant Group described these inequities in access to resources between low income and affluent neighborhoods. And she described, I would say one difference I see between the way my community is treated and another would be like access to healthy foods. There was like a lot of white people and you just notice there's nicer stores, like healthier places to eat. There's not a liquor store on every corner. I just know that there's a big difference. You don't see liquor stores in white communities, like you just don't. So they described that lack of access of healthy foods in communities of color was also shared among women from the pregnant and postpartum groups in both geographies. Women also shared like their concerns of high crime rates as well as drug use in their particular communities in comparison to predominantly white communities. And here's a story from a pregnant woman from Oakland. She said, definitely in my community, most of the parks are like torn up, you know. Some of them, they do have the drug addicts that just have syringes everywhere or the crime rates. So you could have the young children running through there doing the shooting and stealing, so it's more higher up and it's not gonna get answered by, you know, a Black person calling the authorities compared to a Caucasian who runs the building. They come immediately. And they actually arrest someone compared to if I call, they take hours or they might not come and they're probably not going to do anything. Women also shared that there are a lack of locations in predominantly Black neighborhoods where their children can play safely and have access to green spaces to participate in physical activity. So here is a mom from the Oakland Postpartum Group sharing this story. She said more parks for the kids. They need more parks for the kids because the parks is all messed up. We have to go out to San Leandro or Hayward to go to the parks. Yeah, because these parks out here, they don't have swings and playgrounds for kids. And if they do have a park, it's people on the play structure. So Black women clearly described 3 ways in which the government has failed Black communities. So widespread of food deserts, hazardous parks, and the desensitization of perpetual violence in communities of color. So women also expressed that these failures can lead to obesity as well as other health issues within their community and their children's health. So from this work, we then went back to the community to develop policy recommendations for these domains that emerged. And the purpose of this work really was to give something back to the community. So you all know that research kind of moves slow. So we're able to collect these data. It takes time for us to write up these data. Then we submit it to a journal. It takes 6 to 12 months to get published. And so it was really important for this work and the stories that came out that we went back to develop policy recommendations with women So we used the research prioritization by affected communities strategy, and it was developed by Linda Frank and Monica McLemore with other colleagues for the Preterm Birth Initiative. And it's really a process where you generate, prioritize results. And results in that they use this method to generate and prioritize research questions to address preterm birth with the community. And then I use this method to develop and prioritize policy recommendations. So here are pictures of the process that we took to develop these policy recommendations for the domains of structural racism that emerged. And so again, it was a two-phase process. The first phase is we had the definitions of structural racism and women's quotes up on the wall. They did a kind of walkthrough, and they started writing down policy recommendations for each of those domains. They then set those post-its on these posters that you see here, and then we had stickers for them to prioritize which of the policy recommendations were really important to them. And so then my research team then took these and wrote them out and prioritized them, and then we went back with women to really finalize and solidify these. One key thing that we really wanted to do with these data was to develop materials that women can use for themselves to go out in their communities to share about structural racism, this process, what they found. So we were able to work with a graphic designer to develop an infographic that really highlighted some of the domains, their policy recommendations. For each geography, we were also able to develop postcards that really focused on one domain that was most important for each of the geographies. And so this would be something that they can use as an aid or a tool to either mail to someone or just give someone a snippet of what was important to them around this domain. And then we had a more like traditional flyer that had all the domains and all the associated definitions. And again, we did have a community gathering. This time it was in Fresno. It happened this past September. And it was a slightly different format to where we talked with women from both Oakland and Fresno who were involved with both parts of the research, as well as a student who was involved in this work. And one thing that was so moving and that I remember from this experience is that one woman shared that she found her voice through this whole process. And literally at the end of this collaboratory, someone was giving her a card for them to work with her to then start talking about this process and recommendations that they came up with. So I'm going to share the recommendations from the education domain as well as the community infrastructure domain, and really wanting to end this talk today with women's recommendations on how to address this work, their recommendations of things that could be done to solve this issue. So for education, they believe that local policies that expand the possibility of pursuing higher education while raising a family, for example, free college, vocational training with stipends for living, such as housing, food, childcare for Black women, deep and unattached discounts, and no increase in fees everywhere. They also said increase access to higher education by making requirements on college applications more equitable, for example, giving more weight to lived experience and eliminate certain standardized tests as a requirement. Third, to provide equitable access to educational resources and supports to Black children and families in K-12 public schools and surrounding communities. They also said funding to support a Black Center of Excellence to assist with self and career development, building wealth, social cultural capita, technical services, and more one-on-one peer and Black professional mentor and support, group sessions and networking, and funding for expansion of K-12 Black student supportive services such as mental health, professional life coaches. And for community infrastructure, they said local policies preventing higher gasoline prices in low-income communities of color, local policies that acknowledge and give reparations for community land ownership, where all our own food is grown and community gives and receives from it, local policies to expand public transportation laws to allow Black women and families to bring more than 2 grocery bags on strollers on the bus in the city of Fresno. So that is a law. They cannot have strollers on the bus in Fresno, and they can't have more than 2 grocery bags.
That's so hard.
That was talked of like an issue of having to go to the grocery store several times a week, and then also not being able to actually carry enough groceries that they need even for the week.
Oh my gosh, yeah, that's a mess.
They also said local funding and programming to support access to high quality, affordable food, such as farmers markets on weekday evenings, expansion of WIC to include organic foods, indoor farmers markets for access all year round, local funding for monthly Afrocentric events around food, family tradition sharing, infant feeding, recipe swapping, mandate for affordable organic food shops, preferably Black owned in Black communities to replace liquor stores, sustainable funding to start and maintain community centers, garden spaces, and Black-centric programming and gathering for fellowship. And I would like to acknowledge the Black women who are involved in this process, my collaborators, Helena Rega, Sylvia Arabia, Brianne Taylor, Brandy Gates, Loretta Shrugs, Robin Barron, our community partners, Black Infant Health, WIC, Roots of Labor Collective, Black Women Birth and Justice, my mentors, Monica McLemore, Lorgelie Pulowski, Miriam Cooperman, Nicole Santos, colleagues, Selena Lau, and then funding the Preterm Birth Initiative and the UCSF Population Health and Health Equity Award. So thank you all for your time today, and I'm open for questions.
I just want to make a comment and thank you for this amazing amount of work, and it's very inspiring to think about research in a way that really includes community partners and real experiences, not just like a master class.
Yeah.
Right? So I am very inspired. That's amazing. Very, strategies to also engage every single aspect that you're.
Thank you. Yeah, so the question asked whether or not they thought their peers were prejudiced. And so it was a scale from strongly agree to strongly disagree. And we found that on the individual level, that peer inclusion was associated with a decrease in delinquent behaviors. But when we aggregated that at the school level, across all the schools, we saw that there was like a negative association. So as school inclusion, the aggregated variable, as that increased, that we saw that also an increase in delinquent behavior. Yeah, an increase. So when we aggregated the variable, we did, but when we just looked at their individual responses, we didn't. We saw what expected. We said, yeah, I feel like for that one, what we thought was potentially going on is that there are several different schools like across the nation that were within the study. So we felt like we could have done a deeper analysis to look at if there were some interactions between race, ethnicity with those particular measures. It could have been like regardless of like peer inclusion that maybe those variables impacted Black to white students differently. But we didn't do that particular analysis for that paper. We just focused in on Black and white students and looked at all those measures for the group of them collectively. Anyone? I am, so where that is now, so those documents that women created we were able to, at the actual collaboratory, people were able to address the actual postcards to both local as well as policy officials in San Francisco, and we mailed them off in September. We have revised those documents and in the process of making a website where those documents can sit so that women can access them anytime that they want. And we are working on a publication to then put out in the space. I do have an op-ed that came out from the piece with Apolitical where I kind of focused on a few of the domains to give recommendations, but we do hope to use these moving forward. One direct way that it has really informed policy more recently is with the California Preterm Birth Initiative. Jonathan Fuchs, he leads our policy working group, and he's been using some of women's stories as well as our policy recommendations as he's going to talk around, like housing was one policy brief that they went to last month, and then most recently they went to one around mental health issues. So women in this study, they talked about all those things and how it relates to their particular health as well as their children's health. And so as we see those opportunities, we're always inserting these experiences in their recommendations. Yes.
Can't hear it.
Thank you. Thank you for that suggestion. I'll definitely tie back. That definitely seems like that can be a spin-off research project. Like, how could we use this information to then form like a group of mom advocates? And then also what was interesting about this work too, and which I try to not miss, is the preconception group as well. And I think which is really important for you all's work of like how to look at, you know, the reproductive lifespan and how these things are impacting people even before they show up for pregnancy. So thank you for that. I think that's a great resource and idea.
It sounds like even just preventing are part of the process. And I wonder if there's things there to harden about that. If by far, I'm sure I'm not sure that's but just the idea of being able to speak on the road better seems hardened. Policy, I mean, by far much greater than so many others out of
Yeah. Thank you. That's a great. I haven't yet really thought about that, to be honest. And we're not measuring it in any type of way. So for both parts of the study, we work with the same group of 32 women. And so it is, as we're thinking about next steps and what to do with this work, it would be interesting to see how they could then use this information, inform the community and see what comes from that, and how they're able to roll out some of these recommendations within their communities. And that was really why we wanted to do the infographics, and then also the little postcards, because those are ways that they could really just give this information in engaging ways to people in their communities. And really was a way for them to share about their research process. Because it was the first time that a lot of women really thought about structural racism. That was the most challenging and longest part of the first focus group, is really defining it, and I didn't put any of my own knowledge or anything in there. So it was really a moving process for these women, and I agree in that it was an intervention all on its own. And every time I go back to the community, they're really shocked I'm actually coming back, because they're like, this just doesn't happen. I think, yes, that's something for me to really think about, of how this is an intervention. And I have been working with other people to replicate this in other settings. Because I feel like it would be, yes, there are implications for child and adolescent health, but it would be wonderful to also have the same discussion with young people, to see how is it similar, how is it different, what's showing up in their lives. So definitely great thing to think about, and how I could be measuring this moving forward.
Now they're
Negative, right?
Mm-hmm.
Physical.
Right. Mm-hmm. 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 Yeah. Yeah. Mm-hmm. Yeah. Exactly. So it was interesting for like the health outcomes that different groups talked about too. So we did ask them to really focus in on like reproductive health outcomes, but something just like an access to care came up among the preconception group, as in like, because they were also together, they were the women who made like more monthly income. So for our pregnant and postpartum groups, we worked with a lot of organizations who serve low income women. And so they really talked to access, they talked to like access to abortion. Like it was, you can tell that they're just different factors that they were thinking about at that time. But then also being able to think about like their future pregnancies if they did want one. And then also even reflecting, one woman did reflect on her mother and how she was getting recommended to get a hysterectomy instead of other interventions, and she was like in her late 40s. And so it was really, they're really thinking about like other issues, whereas for women who are pregnant and postpartum, it was really talking about their pregnancy, how they weren't receiving great care during prenatal care, talking about fragmented care, like some talked about, particularly in Fresno, their prenatal care and where they went to go get ultrasounds are completely different side of the cities. They don't talk with each other, and so she'd get recommendations from one place and it didn't go to her doctor. And then stuff with their children. So it was really different ways in which they're navigating their life and how structural racism showed up, but that the conceptual frameworks and the overarching domains were true for each of them.
Yeah. I just think from a clinical perspective, the information that we gather really makes me think more about what questions I should be asking mothers and mothers-to-be about their social contacts and what their needs are, and what my job is going to look like, right? When someone has food integrity, right, or disjointed medical care, right? To really explore that more. And also kind of, it also strengthens my belief in that the patient knows what they're talking about, and that they're experts in their own lives, and they can create policy. To be, really amazing, rich knowledge they share with us, right?
Yeah.
So, but that's an important conversation to have with your clients to make sure that there's still equity.
Yeah.
And validate that.
Yes, I'm excited that that's one of the takeaways that you got from here. Yes, I agree with that. I think through this whole process and through my work, even thinking about myself as a researcher in this community work, it's all about how do I even shift power with myself, right? To where I shouldn't have the final say or decision-making power in the research studies, and that we built in where women, like, yes, I put in my expertise, but then also if they're like, no, Brittany, you are off. And like, okay, Brittany is off. We're gonna put this in this way. And so it is recognizing women as experts, and Black women in particular as experts in their health journeys. All right, well, thank you.
So much.